Hey everybody, I'm Dr. Scott Warden, the TOS guy. Welcome to our next live stream. We have a really special guest today. Dr. Arthur Jenkins was on the faculty at Mount Sinai, New York in neurosurgery. He's written dozens of papers, basic science research, hundreds of talks, and he's here today to speak about the difficulty in diagnosing TOS. Thanks, Art.
Thanks, Scott. Thanks for having me. It's a pleasure to be here. First thing, whenever you give a talk, you got to say, hey, do I have any conflict of interest? Is there anything that would make my words not be valid because I've got a vested interest in something else? And the answer is no, I just do spine surgery. What is thoracic outlet syndrome? It's a collection of multiple diagnoses. It's no one diagnosis, but it impacts on the neurovascular bundle, the blood vessels and nerves that travel between the heart and the arm. The thoracic means it's in the chest area. Outlet means it's in the area where structures leave the chest and go out into the arm. And of course, syndrome just means stuff that goes wrong. The anatomy is hard to understand because it's a very high value real estate area. It spans from the beginning of the brachial plexus right here. The brachial plexus are the nerves that come out of the spine and go down into the arm. And it goes all the way laterally to the connection of the clavicle or the collarbone. Then it goes out to where it meets the shoulder blade. So the entire root of the collarbone from here to here is the span of the thoracic outlet. From top, it goes from the level known as C5, which is the first nerve that goes out into the arm, all the way to the bottom on the surface of the rib cage itself, or the thoracic wall. It has a whole bunch of different symptoms. It's determined by which structure in that complex area that's actively being compressed. It can cause pain. It can cause tenderness. It can cause numbness, tingling, weakness in the hand or in the arm. It can cause, in extreme cases, atrophy or just a loss of muscle in the hands or in the arms. But that is a late finding, and you don't want to get to that point if you can avoid it. If it's already happened, that's unfortunate, but there may still be some things that can be done for that. More than one type of TOS at the same time. These entrapments can be caused by different things. There are compression against one of these structures between the clavicle or your collarbone and the first rib, the top of the rib cage. You can also have something called the pec minor syndrome, where your neurovascular bundle is pinched under the tendon to a minor muscle that controls the shoulder blade position, the pectoralis minor. Scalene muscles on top of the rib itself can pinch nerves or even the artery if they're either overgrown or if there's some process that causes them to be abnormal. There is a process called a cervical rib. It's a congenital anomaly where you have an extra rib above the normal rib cage, and that can pinch the nerves coming through. In addition, there are fibrous bands that are very hard to see on imaging, but those can cause twisting or pinching of the nerves. Trauma to the area can sometimes cause a fracture or a sprain that is now a dislocation that's pinching one of the structures going through there. There are certain congenital anomalies where you're just born with weird anatomy. And then there are variants on any one of these that may be slightly different than the normal flavor of any of the ones that we've mentioned already. Now, no one clinical test or radiographic test is universally reliable or specific. There's no one test that says this is definitely TOS, and there's no test that says this is not TOS. But you have to look at the entire picture of what are the symptoms, what are the radiographic findings, what are the clinical findings to determine is it TOS or is it not TOS. The EAST test, EAST, the external, the elevated arm stress test, is when you lift your hand up and squeeze the hand while it's lifted up, and that stresses the hand and shows if you have impaired circulation or impaired nerve stimulation so that the nerves tire very quickly. Electrophysiology, which is where they might wire up your muscles to determine how well they're functioning and determine the nerve conduction, is helpful, but not always. In fact, one of the most experienced neurologists that I've ever spoken to treating this says it's not uncommon to have a completely negative test, even when the patient is having active symptoms. So it's not a precise test, nor does it eliminate people who don't have TOS when they think they do. In addition to that, there's all sorts of different types of imaging. There's CAT scans, there's MRIs, there's different types of x-rays. There are even other types of tests that we can do that we don't usually find useful. Now, one of the other issues that makes it so hard to diagnose is there are other orthopedic and neurologic syndromes that overlap with thoracic outlet syndrome. And there are shoulder problems. People have a slap tear, or they have a dislocation, or they have some other problem in their shoulder, and it may pinch a nerve, but it may not be thoracic outlet syndrome. It's a primary shoulder problem, not a primary thoracic outlet region problem. In addition to that, there are problems in the elbow, even sometimes in the wrist with carpal tunnel syndrome. There are other problems where if you have a rib fracture, that can cause or mimic thoracic outlet syndrome. A tumor of the rib can also cause similar symptoms. In addition to that, neurologic problems like a pinched nerve in the neck, or a tumor or trauma to the nerves in the brachial plexus, but not necessarily from thoracic outlet syndrome. And then cubital tunnel, a nerve entrapment in the elbow, carpal tunnel, nerve entrapment in the wrist. All of these can make very similar symptoms to TOS. So deciding which one this is, you have to make sure you eliminate other possibilities. In addition to that, either TOS is associated with other conditions, or other conditions have symptoms that are very similar to TOS. So there are collagen vascular disorders that often result in thoracic outlet syndrome symptoms, but it profoundly complicates the management. Ehlers-Danlos is one in particular that most patients with Ehlers-Danlos actually are more likely to have a very complicated course if you treat them surgically, but they frequently spiral out of physiologic control if they don't get treatment. So it's a difficult position to be in, is having patients you're kind of damned if you do and damned if you don't. But you do the best you can to navigate between the waves and the rocks. In addition, there are certain vascular conditions, and one of my colleagues in New York is one of the world's experts on a condition known as May-Thurner syndrome. And we've found that there are a number of patients who have a vascular problem in their pelvis that when we treat that, their thoracic outlet syndrome symptoms just feel better. And so that the relationship between the vasculature of the pelvis and the vasculature or other anatomic structures in the shoulder region is fascinating, and we're still exploring that. A lot of patients with neck trauma are more likely to develop thoracic outlet syndrome. Prior spinal surgery. Raynaud syndrome mimics because it's a vascular problem in the limb, but not in the thoracic outlet. Other arthritic conditions either contribute to or can result in similar symptoms of TOS, including ankylosing spondylitis, rheumatoid arthritis, and even generic garden variety osteoarthritis. So one of the next issues is, well, let's say you've made a diagnosis of TOS. What do you do next? And that's part of the complexity. And I think it's one of the things that confuses a lot of clinicians is there's still no great uniform understanding of what the best next step is for every single patient. And we'll get into that in a minute. But first, the first line of treatment for TOS is always physical therapy. But not all physical therapy is beneficial for patients with TOS, and in some cases can make the symptoms worse. Second, bracing has been used as an option. And one of the reasons that seems to work, we'll get to in a minute. But the issue is what drives the pinching is the position of the shoulder blade. And if we can brace and elevate that shoulder blade so it doesn't pinch as much, that can help alleviate some of the symptoms. In addition to that, if you have pinching from one of the muscles, either doing injections or Botox, botulinum toxin injections into those muscles may help, and they may alleviate some of the compression, at least on a temporary basis. Hydrodissection is a process where usually a pain management doctor will take a needle and inject saline or something like saline around the nerves to try to push the soft tissue away from the nerves. It's a new and relatively novel technique for trying to manage the symptoms. I'm not sure it's a long-term treatment, but it may give patients some temporary relief, and that's usually better than getting no relief. And then finally, surgery. And surgery comes in a lot of different shapes and sizes depending on what the condition is. There's arterial, venous, and neurogenic. Each have different need that needs to be addressed. And then once you figure out what the need is, what's the underlying source of the compression or the problem, there are different approaches on how to get there. And there's a supraclavicular, there's an infraclavicular, meaning whether you're going above or below your collarbone. There's a transaxillary where you're going in under the armpit. And then there's also this new technique that I just recently published for taking out cervical ribs from the back of the neck through a tiny little half-inch incision. So there are a number of different approaches, literally ranging from the front to the back. And so which one is right? Once again, the answer is it depends. So interpreting the imaging is actually another reason this is so hard, is that these are very complicated images. And first of all, you got to know what image to order. And the average clinician just doesn't know what to order. If you really don't know what to order and you can't get in contact with someone like Scott, who's got his own patented system of preparing and performing these MRIs that are dedicated just to thoracic outlet, the basic is get an MRI of the chest. But important to understand, get it with the arms up and the arms down, because most patients with thoracic outlet syndrome are only symptomatic when their arms are up. So that's where you want to see what the anatomy looks like. But it's good to compare it to the arms down. But there's a whole, and I'm sure Dr. Worden's going to explain or has explained previously some of the nuances of his very specific and tailored protocols, which I love looking at, and some of them I have examples of here. But you can imagine that when an MRI, let's say you've ordered the right MRI, but interpreting it requires a whole different level of expertise that most, even neuroradiologists, don't have. And I'll tell you that most of these MRIs don't come with these colored arrows already applied. These are my annotations that I have made when I've looked at individual patients' films. And you can imagine that sometimes this stuff looks like you're looking at tea leaves. I mean, how do you figure out what's what? Practice, man, practice. When you're looking at CAT scans, they look at a totally different type of anatomy. They're looking at tissue density, whereas MRIs are primarily looking at tissue water content. What's the difference? It's like night and day. But if you put both together, you get the whole picture, or at least the majority of the picture. What's another barrier to the clinicians being able to make the right diagnosis? Knowing how to take a CAT scan image like this and turn it into a 3D model like this one, which will allow you to actually rotate it around in 3 dimensions and actually see where the nerves and the vessels are being pinched between two structures. And most clinicians either don't have the time or don't have the inclination or don't have the budget to buy the 3D modeling software to do this. In addition, there are some newer studies where we're doing dynamic fluoro imaging, where we're actually getting x-rays of the arm up and arm down to look at what the differences are. So the imaging is not simple. Interpreting it is not simple. And so understanding what the next step is not simple. This is a blown up view just because I think this is really cool to see this. And so I want to drag you through this. Here's the collarbone up here. These are the blood vessels that are coming through. here's a blood vessel coming through here, is coming between the rib and the clavicle. And you can see it's really getting pinched here and here. And on this side, these blood vessels, these veins are actually significantly larger because the blood is backing up into the arm when the vessel is being pinched. So right here, I'm backing it up a little bit, and you can actually see that the rib and the collarbone here are literally scissoring this poor blood vessel. It's no wonder she's very symptomatic. So once assuming you've gotten through ordering the right imaging, interpreting the imaging correctly, now you got to figure out what's the right treatment. Well, the problem is there are some TOS surgeons out there, but all they do is one surgery. Everybody gets a first rib resection, whether that's the right procedure or not. Now, granted, first rib resection is probably 90% of all TOS, but it's not 100%. And so if you do a first rib resection on somebody who's got pectoralis minor syndrome, how are they going to get better? If you do a first rib resection on somebody with a cervical rib, how are they going to get better? You really have to make sure the right diagnosis has been made, because without the right diagnosis, you can't have the right treatment. And so the other issue is, for example, in venous VTOS, venous thoracic outlet syndrome, one of the problems is that the chronic trauma to the vein results in internal bands that develop that promote more clotting. So many patients with venous TOS may present with a clot in a major blood vessel that it can be cleared. But if the injury's been going on long enough, that clot can recur unless appropriate measures are taken to prevent the clot from coming back. And the longer it goes on, the less effective any of those treatments are. Arterial TOS, actually, one of the major mechanisms of injury is you damage the artery so badly you form an aneurysm. And so if you don't resect the aneurysm and reconstruct the artery wall, you're not treating the underlying problem. You're actually throwing clots into the arm. So on top of the whole issue of identifying the individual components, one of my new current hypotheses is that all of this is being caused not because the clavicle, the collarbone's in the wrong place, but that the collarbone is in the wrong place because the scapula, the shoulder blade itself, is not supported properly because of damage to one or more muscles in that area. And that bigger picture issue is not adequately being addressed, because if you fix take the rib out, for example, and take the compression off, the shoulder blade is just going to fall a little further until it starts to pinch it again against the second rib. So we need to start addressing the big picture items as well as the little picture items. One of the other barriers to getting the right diagnosis is a lot of clinicians have kind of given up on TOS. There are some very good outcomes and a lot of papers that report 94, 95% successful outcomes from surgery for up to 5 years. But a lot of clinicians have been practicing for more than 5 years, and they notice that after more than 5, 10, 15 years, a lot of these patients' symptoms come back. Well, I think they're coming back because we aren't addressing the scapula problem, and so the shoulder blade just falls until it starts pinching against the second rib, as well as the chronic injury to the artery or the vein leading to further downstream, subsequent problems. And so it's not without reason that many clinicians think, oh, well, in the long term, these patients ultimately don't do as well as we would like. So why bother even making the diagnosis? In fact, I know some thoracic surgeons who have essentially stopped doing thoracic outlet syndrome surgery because of the long-term lack of efficacy. And so I think that you're doing a disservice, at least for the short-term benefits that you can get from this. But I also think the focus has to be on coming up with both a short-term treatment and a long-term treatment. And so we've got some work to do. Plus, also another reason I think not fair to the patient, but there are a lot of patients in the workers' compensation system, and there are a lot of clinicians who think that a lot of the workers' comp patients, they're just out to get out of work. And that's just not fair to the patients who want to get back to work and just are being treated like they don't. So why are the long-term outcomes not as good? Well, I've already kind of addressed this. If all you have is a hammer, everything starts to look like a nail. If the recanalization, if you get the clot out and then it develops clot again, well, we got to find a better way of preventing that clot. And then we need to come up with other treatments for some of the underlying conditions, especially Ehlers-Danlos, which will treat the underlying genetic deficiencies that lead to developing TOS in the first place. This is kind of one of my central practice philosophies. Seeing is believing, but believing is necessary for seeing. If you don't believe in a diagnosis, you're never, ever going to make it. And so if you don't believe in a diagnosis, you're never going to look for it on the films that you order. You're just going to blow right by it. And that's true of a number of other, what I would call the minor or the orphan conditions. And TOS has kind of become an orphan condition in America today. So most clinicians, they diagnose what they're used to seeing regularly and often skip over the things that are a little bit rarer, what we call in medicine, the zebras instead of the horses. There's an old saying in medicine, when you hear hoofbeats, think horses, not zebras. But if you live in Africa, you should think zebras, not horses. So it really depends on what you expect to see, but also kind of keep in the back of your mind, there may be more than one type of hoofed animal that's running around. Another issue is there's this term called disputed TOS. And I take it as a pejorative term. Disputed means you don't really believe in it. There are people who dispute that it's really TOS. And the definition of disputed TOS is it's thoracic outlet syndrome without hard EMG findings. Well, we've already mentioned that you can have TOS and not have EMG findings. But for some people, they use that as their threshold, as saying, well, if you don't have EMG findings, I'm not going to make the diagnosis. Well, making the diagnosis shouldn't be dependent upon one single test if the rest of the tests all support it. So I actually don't call it disputed TOS. I just call it EMG negative TOS. It's really early TOS because you typically start to see EMG findings at the point where you start to get nerve damage that's so bad that the muscles are dying. So where do we go from here? The first thing is for the clinicians out there and for people who are seeing a clinician, make sure that you or your doctor takes the time to listen to what's going on. And it's very hard in today's data-driven and finance-driven medical environment where HMOs, Obamacare, Medicare reimburses poorly per hour, per minute spent with the patient. So they want to get through the list quickly. So stopping and listening it's almost a bit of a lost art. All these algorithm-driven treatments in electronic medical records that basically take the top 5 diagnoses for a given set of symptoms and expect you to make one of those 5 diagnoses. Well, what if TOS is number 6 and it doesn't pop up on your list of the most 5 syndromes to test for? It requires a detailed physical examination. You have to test for tenderness in multiple places. You have to do an East test. You might want to do a Wright's test. There are a number of different tests that we can do to try to identify where the pain is coming from. And the first issue is you need to believe the patient has the pain. And then you need to believe you can find the cause of the pain. And ultimately, this just comes down to the concept of treat the patient. Treat the patient that's in front of you before you start thinking about the next patient. We need to get better research to validate a lot of the things that we're talking about here even better. Because a lot of the naysayers out there in medicine will say, well, there isn't great class 1 evidence to describe what you're saying. And the answer is, well, I guess we got to get together and the TOS treating physicians need to band together more and come up with large databases pooling all their patients to have class 1 data. Do prospective studies instead of just looking back on, a dozen, 2 dozen, 3 dozen patients you've operated on. Really do joint multi-center prospective studies where we all follow the same rules. we need better modeling of the underlying conditions and coming up with computer models, physical models, and a better mathematical model concept of what's going on will help us to then develop even better treatments that are more effective and less invasive. So that's where we're at. I want to thank you guys for your attention. If there's any questions out there, now's a great time to send them in.
All right, that was really great to listen to that. It hits a whole lot of points that are challenging for clinicians and patients alike. If I could start you with a question from me first. You brought up disputed TOS. How many patients come to you that you find have TOS that have been told by other doctors that the diagnosis is disputed?
I just had one last week where I had I won't say it was a heated discussion, but it was certainly one-sided with the patient's neurologist. And he flat out said, she has at most disputed TOS. I think she's primarily got fibromyalgia. And fibromyalgia is, I think it's 90% overdiagnosed. I think there is an entity of fibromyalgia out there, but I think more often than not, fibromyalgia is the bucket that people put patients into when they can't figure out or haven't taken the time to figure out what the real diagnosis is. For example, 10% of fibromyalgia patients have been found to have Chiari malformations, which cause almost the exact same symptoms that we ascribe to fibromyalgia.
How do the patients respond when you tell them that, in fact, the diagnosis is not disputed? They're just different stages of it.
Right. Most of them are internally grateful that somebody's actually listening to them.
I'm going to read you a couple of questions we have from our viewers. First one is, hi, I've seen multiple physicians in the area that I live. I think I have TOS, but none of the physicians I have seen agreed. Do doctors like yourself do telehealth consults? And this is from Gina in Phoenix.
Hi, Gina. Yes, as a matter of fact, I've been doing telehealth for about 10, 15 years now. And then it's actually blown up in the time of COVID. If you go to my website, jenkinsneurospine.com, there's a process for registering to do a telehealth process. In fact, we actually have initially a free consult with one of my treating clinicians who will do a first pass, and he's great. Everybody loves him, Dr. Wood. So if you wanted to go to my website, that's a great place to start on the process, and we'll give you our 2 cents as best we can. If Dr. Wood goes through your stuff and thinks that it's worth having a second tier consult with me, we can arrange for that too.
The next question says, how can I find a doctor that does hydrodissection for TOS? I live in San Francisco.
Well, San Francisco is a huge medical community, and I would bet that there are any one of a number of places that you could look online and I would Google pain management and hydrodissection and see who is doing it.
And you can contact me through my website. I can help find local docs here too. Next question says, I had first rib resection surgery for neurogenic TOS 11 months ago. I have cervical ribs that are still there because my surgeon did transaxillary approach. I have muscle atrophy in my thumb. Will it just get worse? The arm still aches.
I think the answer is yes. We know that typically if you haven't treated all of the issues that are leading to neurologic dysfunction, it often will get worse. But it probably got a little bit better because you probably had more than one compression issue at the time. And so they did the one they knew how to do. I would certainly recommend you go online to my website as well. And we'd be happy to do, get that first level consult, get in the door, and see if you're a candidate for my minimally invasive cervical rib resection.
And what you've implied from your lengthy discussion is how many variants there are of TOS, and implied is many different kinds of treatment. It's not a one-stop shop, right?
Correct.
So we both know some surgeons who just say, I don't need imaging. I know what the disease is.
Yeah.
I'm going in there and taking everything.
Yeah.
Is there, I mean, haven't we evolved beyond that in surgery to more dedicated, detailed surgery over the past few decades?
I think the answer there is it depends on what you consider a successful outcome rate. My goal is 100% of my patients do well with the surgery that I do for them. If you accept a 90% successful outcome rate, then you're accepting the fact that you're doing the wrong operation in 10% of your patients. And so if all you want to do is you follow one of 2 or 3 different tests, you may miss the variance if you don't do the thorough, like the 12-point inspection, right? You can't just do a 3-point inspection. You got to make sure you do the full 12-point inspection.
We have another question from Ben, who is a TOS patient that I know, young man. He said, I just want to say, I've had the same experience with a neurologist who did an EMG and said I was negative for neurogenic TOS. I had it diagnosed later, fortunately. Glad you are spreading awareness. Thank you very much.
Yeah, I got to say, as a spine surgeon, and I do EMGs on almost every single one of my surgeries, if you don't have weakness already, your EMGs are going to be negative. So if you just have pain, if you have numbness, if you have other physical findings, or if you have temporary weakness that goes away because you're weak when your arm is up, but gets strong again when your arm is down, okay, that's called, differential strength testing, and that's also considered a variant of the EASE test. If your weakness is not persistent throughout, if you're not 24/7 weak, it's going to be negative on the EMGs. I don't consider atrophy, I don't consider permanent weakness to be one of the diagnostic criteria of TOS. And that's why I think that disputed TOS, it's an oxymoron. It's a contradiction. It makes no sense.
I think for our viewers, Asa Wilborn at the Cleveland Clinic, who is a widely respected neurologist, was the one who came up with this classification. And I would point out, and I'm sure Art would agree with me, that in any other entrapment neuropathy, doctors try to treat it, first of all, to diagnose it, secondarily to treat it before you get this muscle involvement, because muscle involvement usually means it's permanent damage. So what Asa Wilborn did, in my eyes, is he took early and late stage TOS. Late stage would have muscle atrophy and positive EMGs. And he would say, wait until we get to the late stage before you diagnose it. To my eye, that seems to condemn patients to a lifetime of disability. What are your thoughts about that?
Actually, I think it's a little bit of it's very myopic. It's basically saying, if you don't have a finding in the thing that I do EMGs. Therefore, if you don't have an EMG abnormality, it's not real. That misses like the entire rest of medical school of listen to your patient, examine your patient, and understand that transient nerve compression doesn't lead to EMG findings. Permanent nerve compression leads to permanent nerve findings.
It's also honestly a little bit of a warning that maybe you shouldn't step outside your field of expertise.
Well, yeah, but they think that they're so used to seeing what they see that it's a self-confirmation bias. They think that if it's not positive on EMG, it isn't real. And that's not the definition. Ben,
the patient that just asked the question, had that experience. And he, I think he felt badly that the person who did the EMG said it couldn't be TOS, it just couldn't be.
Sure.
Fortunately, Ben was very proactive and a smart guy, and he went out and found the answers himself. Otherwise, he could have been searching down 10 other diagnoses instead of the good diagnosis he has now. Let me read you another question from Terry. I think a part of that answer is patience. I refuse to allow our local vascular surgeon to touch me because he only knows of the rib removal. Once we have a bit more clarity, I'll be sharing. So this is another patient I know as well. And I think we're bringing up two things. There are docs who don't know other specialties, who don't know other bases of knowledge. So as you said, they could be myopic and say, without my test, can't be positive. But then there are also the docs who, at least when they recognize TOS, they'll only treat it one way. Now, you said before that a significant proportion of these patients don't need a rib resection. Could you expand on that a little?
I think it's about 3 to 5% of patients will have a pec minor syndrome, either isolated or in conjunction. So you might do a rib resection, but if you don't also release the pec minor tendon, you're not going to get as good as if you just do one, or if you do both. The cervical ribs, and I saw there was a question on there also about the cervical rib approach. If you have a cervical rib and you don't release the issues about that are related to that, which includes additional fiber spans, it includes compression on the vessel as well as on the nerve at C8, which is hand. And so if you don't treat that, you're not going to be in the process of getting better, and it will likely continue to get worse. And cervical ribs also make up like 3 to 5% of the cases. So granted, the remaining ones are either compression from the scalene muscles, which attach to the first rib, or compression between the clavicle and the first rib, which therefore involves the first rib. So if you take out the first rib, you take it all the way back to the scalene muscles, you'll release the scalene muscles, so you'll get both the entities with the same operation. Mm-hmm. So that's why a lot of people will do well with one operation as long as the one operation is done right.
And if you take a lot of things out? If
you take everything out, you're more likely to have complications. So I don't advocate that. So I saw there's a question just about the cervical rib operation. It's a 1/2-inch incision on the back. The way I do it is day surgery. And I sneak in at a very, very particular angle. It's different than what other people do. And I was able to figure this out with a lot of 3D modeling that we did with virtual fly-throughs and things like that. And the answer is I just come down on the outside of the spine and I follow the cervical rib around and just drill it out and disconnect it from the fibrous attachments that it may have all the way to the front. And that releases any compression that there was on either the vein or usually it's the 8th nerve, but it could also get the 7th nerve in that area. So it's a beautiful operation. It takes about an hour and a half to do. It's an outpatient procedure, a 1/2-inch incision, and but it's not, it's published, but it's not widely practiced.
And then one thing I'd like to reinforce, which you talked about, all of these tests that we have are challenging imaging tests because that's my field, are challenging to produce and to read. And I have found it incredibly valuable for the patients that I interact with, Art, to be able to work with someone like you, because the combination of the clinical team, a doc, whether it's a neurologist with a surgeon, along with physical therapists or other parallel healthcare workers, along with a radiologist, I think that has tremendous power. If this were low-hanging fruit, we would have had one specialist dedicated to it. But as you know, in some cities, it's vascular surgeons. Some cities, it's neurologists. Would you care to comment on that value of a team helping patients with TOS?
I couldn't agree more. I mean, I think that it takes a village to take care of patients. And you have to have a team of people that you can work with. You can talk if I've got a question about a particular patient, maybe I call you up and I say, hey, I need a variation. I mean, we need to do it a little bit off the normal menu because this patient has slightly different symptoms than normal. We got to image them in this slightly different position. And when you have people who understand the anatomy and their imaging and can help tailor the treatment to the individual patient, then you can really help a larger swath of people. But I also think that the key is you got to find people who are bridge builders, not dam breakers. And that, so for example, I do my surgeries with vascular surgeons. So we're actually working, there's a vascular surgeon on one side, neurosurgeon on the other, doing the operation together. And then that allows us to communicate. We share patients, we share information, we share insight. They teach me, I teach them. And that spreads knowledge instead of keeping knowledge in a silo where you're doing the same thing over and over and nobody's telling you that maybe there's a better way, or maybe some of the things you're doing aren't working.
Also, for example, if I ask you, Art, why do you need to get this piece of information? Why does this make a difference? You know, I have to challenge myself. When you say to me, Scott, I don't get this, right? I have to learn something. I have to figure it out.
Right.
So
No,
for
it's
patients,
definitely pushing each other is a bit much better place than getting complacent and doing the same thing over and over and thinking everything is just fine.
as shown by your new minimally invasive approach, something
Yeah.
that wouldn't have happened if you did the same thing for 20 years.
Right.
Awesome. I'm going to let you make any closing comments you want to make. It's a great talk to listen to. We also heard we have another talk coming up. I'm talking to our moderator here because we have another talk coming up, and I am going to find it and let people know when that is. Bear with me for a second as I look at my calendar.
February 16th, 2021, the limitations of standard physical therapy with thoracic outlet syndrome. Looks interesting. I mean, that's, as a surgeon, we don't always get the insight on the physical therapy nuances, and that's something I think not only patients but clinicians need to know more about too.
Excellent. All right. Do you have any closing comments, Art?
I would just say, for clinicians out there who are observing, listen to your patient. Learn what you don't know, because it's not what you don't know that gets you in trouble in life. It's what you know that ain't so. And so you've got to keep an open mind. You've got to believe in your patients, and you got to believe in the diagnosis before you can see it. And for the patients out there, you know, you hear it before, you'll hear it again. You got to be your own advocate. If you don't feel people are listening to you, and if the doctor can't explain to you in a way that makes sense to you what's going on and what the treatment plan is going to be and why the treatment plan is going to be the way it is, find somebody else. I mean, it is what it is. I hate to say it, but by the definition of average, half of all doctors of every specialty are below average. Half are above average and half are below average, and average is right down the middle. So 50% are above average, 50% are below average. If you wind up with somebody who's in the below average in a particular field, find somebody who is above average.
Words of wisdom. Advocate for yourself. Find good specialists.
And listen to your patients.
Thanks to all of our viewers. We really appreciate you attending. Go visit the toseducation.org website for our next talk. Go see Neurospine?
JenkinsNeurospine.com.
Neurospine.com. All right, Art, thank you very much. And we'll see you
Thanks for
soon.
having me, Scott. This has been a real pleasure.